Welcome to Roadmap to Residency. Hello everyone, I am Abhiraj. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on your journey to a 250. So, which of the following is the characteristic feature of the myotonic dystrophy? A 25-year-old man presents with progressive muscle weakness, particularly involving the facial muscles and distal extremities. He reports difficulty with tasks such as gripping objects and climbing stairs. On examination, there is bilateral ptosis, a waddling gait, and a weakness on the neck flexes. His family history is significant for similar symptoms in his father and uncle. Serum creatine kinase are markedly elevated. Genetic testing confirms the diagnosis of myotonic dystrophy. Which of the following is the characteristic feature of myotonic dystrophy? Hypertrophy of affected muscles, absence of genetic anticipation, cataracts, normal serum creatine kinase levels, increased deep tendon reflexes. So, cataracts. Myotonic dystrophy is an autosomal dominant neuromuscular disorder characterized by the progressive muscle weakness and myotonia, delayed relaxation of muscles after contraction. It is caused by an expanded CTZ trinucleotide repeat sequence in the DMPK gene. There are two major types, type 1, DM1, and type 2, DM2. Now, this patient's family history and symptoms are indicative of myotonic dystrophy type 1. Characteristic feature of myotonic dystrophy include cataracts, which are particularly posterior subcapsular cataracts, are a classical ocular finding in myotonic dystrophy. Other features of myotonic dystrophy include facial weakness, ptosis, neck weakness, leading to the characteristic hatchet face appearance, myotonia, and distal muscle weakness. Now, let's talk about Becker's muscular dystrophy. So, it is a milder form, later onset than the Duchenne muscular dystrophy. Symptoms appear 10 to 20 years of old. Intellectual disability, contractures are not as common or severe as Duchenne muscular dystrophy. Cardiac fibrosis may be predominant presentation feature, starting with right ventricular involvement and left ventricular dysfunction later. So generally, the questions in the step 1 and step 2 CK, they test about the cause of death in the dystrophy patients. So they confuse you between the cardiac and respiratory failure. So I will always go with cardiac failure because whenever you go and check the internet and check all the textbook and literature, they just tell you the cardiorespiratory failure. But the main cause is always cardiac failure. Diagnosis is by increased serum creatine kinase, mutation in the dystrophin by DNA test or Western blot, muscle biopsy, which is the stain for dystrophin. Treatment, there is no cure for Becker muscular dystrophy. Although we can use some muscles like some medications like glucocorticoids to slow the muscle degeneration. Other interventions may be vitamin D, calcium supplements, support the bone health, physical therapy, and a conditioning complication management. So let's talk about Duchenne muscular dystrophy. So it is caused by the absent dystrophin gene due to the nonsense or frame shift mutation. Okay, so case of Duchenne muscular dystrophy does not make dystrophin. Okay, now complications are the patients are generally wheelchair bound and they suffer from scoliosis. Now scoliosis will lead to the poor pulmonary function. So weak diaphragm leads to respiratory failure, okay? And fibrosis progression in the dilated cardiomyopathy and mitral regurgitation may develop. The patient can also develop dilated cardiomyopathy, which can in the later stages may develop to heart failure and arrhythmias. There is a falling due to the arm and falling which can lead to the arm and leg fractures. Whatever compression fractures with corticotherapy, respiratory insufficiency or cardiomyopathy causes the death. Again, you have seen here that both the respiratory and cardiac causes are mentioned here, but you should always go with the cardiac causes. Or if the option says cardiorespiratory failure, then that is the best option ever. Now, signs and symptoms, more severe dystrophinopathy from is the DMD. Symptoms usually appear by 5 years old. Weakness usually occurs 2 to 3 years old. Walking begins later in the childhood, may have slow, ungainly run, difficulty jumping, walking up steps, proximal limb muscle weakness before distal lower extremities, before upper. And then we can see the Gower sign, Warling gait or calf pseudo hypertrophy. Now, this Warling gait and calf pseudo hypertrophy is the most characteristic sign of DMD after Gower sign. Decreased mobility may lead to independent ambulation impairment, wheelchair use by 12 years old. Primary dilated cardiomyopathy may be there, and also conduction abnormalities may be present. Here you can see the fibrosis that is there and the atrophic myositis. These one and these one. Again, here you can see the muscle biopsy from an individual in the later stages of Tuchel dystrophy. You can see the fatty replacement, and this fat causes the pseudo hypertrophy of the muscles. The muscles may seem big, but because it is due to the fat replacement, they are not strong. Treatment, there is no cure again for DMD. Glucocorticoids may be used, and other interventions are same as the Baker's muscular dystrophy. The vitamin D, physical therapy, and complication management. Here also vitamin D, physical therapy, and complication management. So let's summarize all the muscular dystrophies, the Duchenne, Baker, and the myotonic dystrophy. So the Duchenne and Baker are due to the X-linked recessive deletion of dystrophin gene on chromosome number XP21, whereas the myotonic dystrophy is the autosomal dominant expansion of a CTZ trinucleotide repeat in the DMPK gene on chromosome number 19. Now, the clinical presentation of Duchenne is the onset is 2 to 3 years, whereas the Baker is 5 to 15 years, and the myotonic is 12 to 30 years. There is progressive weakness, Gower maneuver, calf pseudo hypertrophy in case of Duchenne's. There is milder weakness compared to DMD, and in myotonic generally there is the facial weakness and hand grip myotonia. The comorbidities are the scoliosis, cardiomyopathy, Baker cardiomyopathy, and myotonic arrhythmias, cataracts, balding, and testicular atrophy and infertility. Prognosis: the Duchenne patients are generally wheelchair bound by adolescence, and death occurs at 20 to 30 years from respiratory or heart failure. Baker, death by age 40 to 50 from heart failure, and myotonic, death from respiratory failure or heart failure depending on the age of onset. Now let's do one more question here. So which of the following is a characteristic histological finding in polymyositis? So a 50-year-old man presents with a severe, with a several-month history of progressive symmetric weakness involving the proximal muscles, such as the shoulders and hips. She also complains of difficulty rising from a chair and combing her hair. On examination, there is muscle atrophy, weakness, and an elevated serum creatinine kinase level. Electromyography reveals short duration, low amplitude motor unit potentials. Muscle biopsy demonstrates the endomyosial inflammation and perivascular atrophy. Which of the following is a characteristic histological finding in polymyositis? Rimmed vacuoles, red fibers, targetoid fibers, central nuclei, or split fibers. So rimmed vacuoles. Polymyositis is an autoimmune myopathy characterized by inflammation of the skeletal muscles. The characteristic histological finding in polymyositis is the presence of rimmed vacuoles within the muscle fibers. Rimmed vacuoles are eosinophilic membrane-bound vacuoles seen in the sarcoplasm of muscle fibers, particularly at the periphery of the fiber. Additional features of polymyositis include endomyosial inflammation, that is the infiltration of inflammatory cells between the muscle fibers, perivascular atrophy, atrophy of the muscle fibers at the periphery of the fascicle, and lymphocytic infiltration. Now, these features are very, very important regarding the USMLE step-1 examination. They typically ask you the histology of the polymyositis. The endomyosial inflammation and rimmed vacuoles are considered hallmark histological features of polymyositis. Now let's review your first stage from the polymyositis and dermatomyositis part. Now polymyositis, it has non-specific positive ANA, increased CK, but the specific finding is positive anti-Jo1 antibodies. Now this anti-Jo1 is also tested in the step 1 examination. Also there is a positive anti-SRP and positive anti-MI2 helicase. Polymyositis, there is the progressive symmetrical proximal muscle weakness characterized by the endomyosial inflammation with CD8 plus T cells, and it most often involves the soldiers. Dermatomyositis, clinically similar to polymyositis, but also involves the Gottron papules, photodistributed facial erythema, example heliotrope rash, okay, sol and face rash, a mechanic's hand, and there is hyperkeratosis of digital skin. There is increased risk of occult malignancy. So the histology is perimyosial inflammation and atrophy with CD4 plus T cells. So I again tell you that please remember the histology of polymyositis and dermatomyositis, with these are typically asked in the USMLE step 1 examination. Also remember that the polymyositis and dermatomyositis have a specific anti-Jo1 positive. Thank you for watching.